morning and welcome to Resolutions for Recovery. This show is dedicated to the education and empowerment for people, for all people that are struggling with the disease of addiction. And that goes for the family as well as they're the affected person who's actually doing the substances and or alcohol. Tonight we have a very special guest, Dr. Michael Delman, extraordinaire.
Thank you.
Who is now the president
Yes.
of the Addiction Medicine Society,
New York Society.
New York Society of Addiction Medicine. And you are just a wealth of information anyway. So it's always a pleasure to have you on because you just can impart really such great knowledge for everybody in the audience that just has questions on all different aspects of the disease. But tonight we're going to really concentrate on medication-assisted treatment, which is, I guess, not entirely new, but now when we, in today's world, when we talk about substance use disorder, people automatically go to the heroin opiate epidemic. But there's an awful lot of other substances and or behaviors that can go along with addiction. So tonight, though, we'll work on, since we have so many people struggling with heroin and opiates, the medication that really can help them achieve sobriety and then be weaned off that drug at some point in time.
Well, Linda, we've come a long way in terms of understanding both the complex nature of the disease as well as finding interventions that are effective, or at least effective in many cases. Obviously, it's not one size fits all.
Yeah.
And it's easy for people to understand what medication-assisted treatment is. Firstly, it's important to understand that the majority of patients require psychosocial treatment in addition to medication, and that's why we call it.
So psychosocial treatment is 12-step fellowship, outpatient or inpatient, right, counseling,
Right.
With a therapist, just so people
Correct.
know what we're talking about.
And there are many reasons for that. Lives are destroyed by the addiction,
Yeah.
and these people are experts in helping the individual put their life back together again.
Yes.
Oh, joblessness is a problem, homelessness is a
Yes.
problem, and so that component of it, which is not a medication, is really very, very important.
Yes.
There is a subset of patients, not that many, but there are patients who do not require anything other than medication. There have been some nice studies that have demonstrated that there's a group of people who take the medication, respond to the medication, continue on it, but don't require the psychosocial component. Now, there are a lot of factors that go into that, what their socioeconomic status was and still is, what their support system was and still is, what their job responsibilities were and still are. And so there are that little group that just gets medication, they do fine. So we're going to talk about different medications first. We have, first, before we start that, we need to have a little understanding about what the drugs do and why we have medicines that can help out with that. So the important thing first is that people start to use drugs for various reasons. Mm-hmm. Sometimes they use it because they've had pain, and sometimes they use it because of another reason, or just experimentation, particularly with our young people. And certain groups of people, and we're starting to identify who's at highest risk, become addicted. So the first thing to understand is that using something chronically is not the same as being addicted to it. Okay. So we have people who do take opiates for pain medication.
Right.
Have been taking it for years, never exceed the number of pills that they've been prescribed. And at the same time, if you stop them suddenly, yes, they go into withdrawal. So we say, yes, they're dependent. And at the same time, they may be able to handle more medication than you and I can handle. So we say, yes, they're tolerant. But tolerance and dependence do not define addiction. While they may be present, they don't define it. Addiction as I said, is a complex brain disease where there's a preoccupation of, in terms of obtaining and using a medication or an action, as you pointed out in the beginning, despite adverse medical, social, or economic consequences.
I know with my own son, to watch, you knew when he was getting, you know, he had to start the pacing, and I could almost watch his wheels turn, that he needed to go get something. He needed to do that.
Yes.
It wasn't that he wanted to, he had to.
Right. Now, to understand how medications work, you understand just a little bit about what the most reinforcing part of the brain and therefore addiction is, and that is in the release of dopamine. And dopamine is a chemical in the brain. We call it the feel-good chemical, if you will. And if your audience wants a little experiment they can do on their self, what I would say to them is think about something that you eat that you hate and you would never eat. And what you feel is, ugh, right? Now think about something that is really, really good that you like. Most people like ice cream. And when you think about ice cream, you start to feel warm all over. That's dopamine. You've just released dopamine. It's called hedonic tone. Hedonism meaning, you know, something that you like to do, etc. That's
well, Dr.
hedonic
Dewey,
tone.
even a cup of coffee, when you smell the coffee in the morning, how you start to get that
and that's
whole
dopamine
feeling,
Sure. And it's important that you brought that up, because understand that you're not just getting that good feeling from the smell alone, but the thought of sitting down and relaxing and maybe talking to your loved ones or reading a newspaper. So it becomes sort of like a global event. Right. And that's important to understand, because that's addiction takes over that. Right.
It's the whole act.
Absolutely. So that release of dopamine comes from many places, but predominantly the mu receptor, that's the name, it's a Latin symbol, mu receptor. Okay. It releases dopamine. And virtually all substances of abuse somehow cause the dopamine to be released. Okay. So what if we could block that? So issue number one is, let's find a chemical that blocks the release of dopamine. There'd be some side effects because you're not getting that feel-good chemical, but at the same time, you know, it's going to block your ability to get high on an opiate. Okay, so we got a drug. Originally, and it's 60, 70 years old now, is called naloxone, and people know it as Narcan. And that's the drug that's used to reverse opiates because it pushes the opiate off the mu receptor, and it blocks the mu receptor from acting. It doesn't let the mu receptor release dopamine. The opiates, when they get on the mu receptor, they stimulate it to release tons of dopamine, and that's why people feel good with it. Okay. So we've blocked it now. But Narcan, naloxone, only works for about 60 to 90 minutes.
Right.
So what good is that? I got a 24-hour day. I got somebody who really wants to use these drugs. And so what was developed over the course of a lot of study, et cetera, was a long-acting form of naloxone, which we now call naltrexone, that's the chemical name, and which your viewers probably know as Vivitrol.
Vivitrol.
So Vivitrol is a long-acting form of naloxone, and when you give a person a dose of that, and you have to give it to them into the muscle, because it's a heavy injection, so you give it to them into the muscle, and now it blocks the effect of the opiates. It actually stops the mu receptor from, yes. Now, unfortunately, it's not 30 days, we take it and it stays up 30 days in your blood. It actually comes up very fast in the first 48 hours, and then over the next 28 to so days, it starts to taper off. So what we find is that, wow, this drug really looked pretty good, but look what happens starting around the end of week 2 and really 3 and 4. It's tapering down, and now we find that some of our addicts are actually able to gather enough opiate to overcome the blocking effect of the naltrexone, the Vivitrol, and unfortunately they can overdose because they get this whole bunch of stuff and they end up overdosing. issue number one. But it works. And in fact, if we can keep people on it for a long enough period of time, the longer you keep someone on it, the better your chances of them staying in a long-term recovery.
It takes those cravings away, because those cravings that you want, you know, when your day revolves around, how am I paying for my next fix? When am I going to have my next fix? And when am I going to have my next fix after that?
So it's a
takes your
global,
life away
it's a
from you.
global response, like
Yes.
the coffee response is over your whole brain. So yes, there seems to be, for certain people, a reduction in the craving. There are many experts in the field that feel that maybe it doesn't reduce the craving in so much as it has a central nervous system effect, but it may reduce the craving because the addicted individual recognizes that they're just throwing money down the drain by trying to
Okay,
get
okay,
high.
which
Whatever way it is.
whatever way it is.
Right. In any event, so that's one drug, and as I said, if we can keep people in it for a long period of time, taking it, and helping them in the meantime recover from the other parts of the addiction cycle, which is obtaining the drug and getting out there and getting money for it and this and that, and maybe getting a job and being able, because it doesn't impair you.
Right.
Right. So if you were, let's say, a train engineer, a safety-sensitive job, assuming that you could stay in that position, and that's a whole other ballgame.
Yeah, that's a whole
But
other
if you had a job like, or just driving a car, you can now drive a car because you're not high.
You're not
So
impaired.
you can go
right.
to work because you're able to concentrate on your work. So it helps, certainly helps, and the longer you stay on it, the longer you stay in any form of recovery, the better your chances of having even a longer recovery.
You know, anything that gives that person struggling time to talk about whatever trauma may have prompted them to start using drugs, to escape pain, self-medicate, right? Whatever it is, whatever blocks them from going back out on the street is well worth the effort.
Right. So then the next drug we came up with, also a drug that's been around for 60, 70 years, is a narcotic itself, methadone. Now, the federal government, when this was first developed, said, oh, well, we can use this drug. It's a very active painkiller. It's a mu receptor agonist, meaning that it actually stimulates the mu receptor to put out dopamine, but it has an advantage. The advantage is you can take it by mouth.
Right.
You don't have to inject it. And after a while, people develop tolerance for it, and because it's an opiate, they don't need another opiate. So people say, well, you just traded one addiction for another addiction. No, you didn't. You're no different than a diabetic who requires insulin. You're
Correct.
giving them this medication. They take it by mouth. They can function normally with it. They can drive cars. They can do other things. Again, you know, there are parameters that, you know, have to be met. The drawback with it is purely one of, you have to go every day initially.
Yeah.
It's controlled by the federal government. There's a lot of red tape involved.
Yeah.
There are not a lot of clinics around. If you live upstate New York, you could have to drive 120 miles
Yeah.
to get to a methadone clinic. You got to be there every day. So it's
Yeah.
240 miles. So that becomes a problem.
And there are waiting lists for some of the clinics that are around.
And the only thing I'd like the audience to be aware of is you're 100% correct. You could wait 2 weeks to 2 months to get into a methadone clinic unless you're pregnant. If you're pregnant, you can get into a methadone clinic within 24 hours.
Does that affect the baby? Will the baby be born dependent?
Yes, the baby will be born dependent, but the doctor's going to know about that,
Right.
and so they can handle that, and that will take care of the withdrawal. But it is very, very dangerous, and we highly, and the American College of Obstetrics and Gynecology recommends that we do not detoxify pregnant women.
Okay.
Now, there are some states where they demand that, or they have criminal penalties, etc., for women who are addicted, which is unfortunate. I think it's a lack of understanding about the disease, and they still think it's willful misconduct, and they're
Yeah.
putting the child at risk. And while that may be true, it's not willful. I mean, you don't know mothers that want to be
No
addicts.
mother wants
right. So
to harm their baby.
So in New York State, at least, we say, okay, but it is still a federal program, so you still
Right.
need to go there and comply with the federal rules and regulations, and it may take months or a year, depending upon the program, before you get trustee status, which allows you to get maybe a month's worth
Okay.
of methadone to take home. The advantage of methadone, though, is that since it's been around so long, we are very familiar with its use, with its side effects, with the upside, the downside, etc. And the data on methadone, people on methadone, is really very positive in terms of remaining in recovery. So even though there are some hiccups along the way, our experience is that this is really working out well for addicted
Do they get,
individuals.
does a patient get, do they have to increase the dose that they get, or it's always the same dose
Well,
for their lifetime?
They increase the dose up until a stable dose is reached, and then
Okay.
they just stay there. Usually it's 80 to 120, 140 milligrams a day, but some people are higher. Very few people are lower because it doesn't block. Remember, you're taking an oral opiate to block your desire for any other opiate.
Yeah.
So that's what happens. So that's the second drug. Now the third drug has also been around a relatively long time, but we haven't been using it that often. And in fact, they used it in Europe more frequently than they did here. But in Europe, they used it for pain management, and here we tended not to use it. I can't give you the reason why,
Okay.
except that it is not just a pure mu receptor stimulator agonist, but it's also partly an antagonist. So it combines both the methadone component as well as the Vivitrol component, and it puts that into the patient in the form of buprenorphine. Now, somewhere along the line, somebody decided that if buprenorphine comes either as a tablet that you put under your tongue, or
Suboxone, right?
Suboxone, and I was going to get to that with what they decided, or it comes as a film. And so, the street chemists, being very, very bright people, figured out a way to dissolve almost any chemical.
Yeah.
That's what we had with the long-acting opiates, is we thought we had a blocking agent because it was long-acting. They figured out how to melt it down and inject it.
The people struggling with substance use are very brilliant people.
Well, the people making a profit from them are
Yes.
very brilliant. So, what they did was they decided to add naloxone, that Narcan I told you about, that short-acting Vivitrol, if you will, into the pill, and that's how you got the Suboxone. And the theory was, well, if you found a way to melt it down, or you found a way to draw it out of the little
The
film, and you injected it, the naloxone would block the effects of the drug, and you wouldn't get a high from it. Well, that's not true.
Yeah.
By the same token, the naloxone is destroyed by the saliva in the mouth, as well as in the stomach. So the buprenorphine would be absorbed, the naloxone becomes inactive, so you don't have to worry about it when you're taking it sublingually. Okay, well, having said that, we'll forget about the chemistry, about why it's ridiculous to add the naloxone to the buprenorphine, but it's there, and that's fine.
Okay.
There are also forms of buprenorphine that don't have naloxone added to them, but naloxone is very, very safe, Narcan. We've had it for 60, 70 years. No deaths caused by it, stuff like that.
And if you give Narcan to someone who you think is overdosing, it won't hurt them in any way if they're not.
So. That's a very important point you've made. So that's correct. No matter what they've done, if you give them Narcan, it won't hurt them. And if your baby happens to get a whiff of it, won't hurt the baby.
Right.
But unless the baby's an addict.
Yeah, which we're going to hope not.
Yeah. So now we have this buprenorphine, which is a mixed agonist-antagonist, and what happens is because it has that ability to block the mu receptor, it has what we call a sealing effect. So you can use it if it's the first time you use it, as is sometimes used in the street, you get a little high from it. But if you keep using it, the high disappears, and because the buprenorphine has a a higher affinity. It means that the mu receptor likes the buprenorphine better than it likes opiates. The buprenorphine locks onto it and blocks the opiates from getting there. So they can't stimulate it. It did stimulate it a little bit, but it had that ceiling effect. So, you get on a dose of it, and you're blocking all of the opiates, and you're getting that little bit of opiate effect. So it takes away the craving, and now it allows you to get into a treatment program. The nice thing about it is not being controlled by the federal government so much. I mean, they
It's
do
a
have
controlled
rules on it,
substance,
right?
yeah.
But you can get it for 30 days at a time.
Yeah.
And we're not really worried about it. Yes, some of it could be sold and is, and some
Yes.
of it can be abused and is. But overall, the benefit so outweighs that negative side effect that we don't really care in addiction. Other people, maybe law enforcement cares,
Yeah.
but we don't care. And so those patients are able to start functioning again at a normal level. And there's no limit on how long you can take methadone or how long you can take buprenorphine, or for that matter, how long you can take naltrexone or Vivitrol. The issue with Vivitrol is it's given by injection right into the muscles of the backside, and that is it's a big injection and it hurts. So that's an issue.
Are they looking for Vivitrol to make it like a chip that can be used for months at a time?
So they do have one that can be used for up to 6 months. And strangely enough, all they did was multiply the cost per month by 6 to come out with the price. So it's about $6,000.
Oh, wow.
However, they just recently, starting today is the 28th, tomorrow is March 1st. On March 1st, 2018, they are releasing an injectable form of buprenorphine that will last a month. And that's given by injection, but it's a regular small injection right into the belly.
That's a great.
Right. So that's being released tomorrow, and
because telling someone who's addicted to now take your drugs responsibly, one every day, is kind of
Yes.
an idiotic statement.
Correct. So you're correct, and even people who intend to take their medicine exactly as directed, physicians included, can't do it.
Right.
So even what you look at is people who are saying the best one is birth control pills. Women have to take it once a day, right, for a month. Maybe they're off if they have a special one, they get off for a week and then start it again. And yet there's still a pregnancy rate related to what?
Yeah.
Forget it. That's only once a day.
Yeah.
Now, if you go to twice a day, that number drops off even further. So if we look at medicines that are prescribed twice a day, only about 85% of people will do that, and that's only for a limited period of time, so maybe 10 days, 2 weeks, something like that.
Oh, absolutely.
If you go to 3 times a day, it drops even further. When you get to 4 times a day, and this is why I say even physicians, I remember getting penicillin, take it 4 times a day for a strep throat for 10 days. So you get 40 pills. And at the end of 10 days, you still got 3 or 4 pills left. What did I do?
When did I forget that?
And then even worse
Yeah.
is instead of throwing it away, you put it in your medicine chest, which is really another issue.
Yes.
But I mean, there may be one thing with penicillin, but unfortunately we tend to do that
with all
narcotics.
Drugs. Yeah,
right?
with narcotics.
And that's a problem. And yet it's sort of like built into our psyche as a capitalist system. I paid for it, it's mine, I own it, I'm not throwing it away.
Absolutely.
And unfortunately, that leads to problems.
That leads to big problems.
Yeah. So you're correct, though. To get back to the to the Suboxone, you're correct. And again, that's a brand name, and you have to use it, at least once a day, and frequently we
Sometimes
give
twice.
it twice a day.
Yeah.
And that's really just because we think maybe, there's something special about that. I don't think so. Buprenorphine has a long duration of effect. It's usually about 30 to 36 hours in terms of its effect on you. And so you could probably take it once a day, but we don't tend to prescribe it that way. We usually split the dose.
That's the one, though, that you have to be weaned off of when you want to come off
Yes, and
of
we'll
it.
talk about that also, maybe in the second half of the
Yes.
show, because there is a big concern that addicts have, and sometimes their families say, my God, they're going to throw him in jail, he's going to go into withdrawal, he's going to die. Depends on what you're addicted to.
True.
So it can happen if you're addicted to alcohol or benzodiazepines,
Right,
it's the
Xanax,
Valium and Xanax.
yeah.
And that is a new issue, by the way. That issue, the death rate for benzodiazepines has been going sky high over
Sky
the
high,
last.
because everyone's on them.
Yeah. So that's another issue.
It's a whole nother issue because, yes, I'm sure there's a place in some people's lives for that, but dealing
For
with
a short
work-
time.
Yes.
And they work beautifully for a short period of time.
Yeah.
But when you look at them long term, they actually reverse their effect. So frequently people taking benzodiazepines over a long period of time end up not only addicted to the benzodiazepine, they're highly addictive also, but they also tend to get the exact opposite reaction to what they wanted. So while they took it for anxiety, chronic use of it produces anxiety. Or may produce anxiety, I guess is a better way of saying it because everybody's different. Chronic use of it and suddenly stopping it can result in seizures. It's like alcohol. It's
Yeah.
almost exactly like alcohol. So that's a potentially deadly withdrawal. And the problem we have with that withdrawal is that we don't have a good substitute. So generally speaking, we use the same thing, the benzodiazepine. Phenobarbital could be used, but that has a very narrow therapeutic margin, so it's very dangerous to use. Is that for us?
That's for us. We're going to be right back after this message.
My age is 18 years old and my name is Evan.
My name is Sean and I'm 19 years old.
My name is Justin, I'm 16.
My name is Angelica. I'm 18 years old.
Marijuana, and I was 13 years old.
Marijuana, and my age was 13.
The first drug I ever tried was marijuana, and I was 12 years old.
It was marijuana and I was 11 years old.
Yes, and that escalated to promethazine, lean.
I began to take pills like Xanax, Percocets.
I began using other substances such as pills and alcohol.
I then went on to cocaine and pills and quickly progressed to heroin. I was 13 years old when I first started using heroin. I had aspirations of going to an Ivy League school, and that quickly, within a year or two, changed. I stopped going to my classes, I stopped going to school altogether eventually. All my friends were kind of just dropping me.
I started getting in trouble in school, eventually kicked out. I got in trouble with the law a lot.
I wasn't really hanging out with a lot of sober people, just people that use. I overdosed at 15. I've been at Outreach for 5 months. Outreach honestly really helps you. It shows that you're honestly worth something. And it's possible to become sober if you put in progress. But it's not just gonna be handed to you, you really have to want to change. Inpatient, you can't just leave. You stay here and you have to deal with it. That's what I feel like a lot of kids need.
In a long-term facility, the counselors get to know the resident better, and they get to actually work with them more than in a short-term 28-day facility. And it really gives kids a chance to work on themselves rather than being rushed through a program, just to be thrown back into life, going back into the same old bad habits that they were doing before.
Coming in here, I couldn't believe how long I would have to be here, but after a couple months, talking to counselors, I kind of came to the realization that I need a lot of time and work to repair everything I've done.
The things that we get taught here, it really does help you in life, and it gives you a different perspective. It's very important for a kid to have a family involvement in treatment so they don't think they're alone in this. We communicate on a better basis than how we used to. We understand each other more, and that was from the help of outreach.
They come every Wednesday night for support group. They come to a group every other week.
They come to parent support group to discuss their problems also. My relationship honestly has got a lot better. Because I remember my mom used to never want to say anything to me because she would be scared of my reaction. I'm starting to realize in here, like, I really have to take advantage of the fact that I have her still.
When I was about 14 is when my parents realized that I had several different problems, such as behavioral issues, and the behavioral issues kind of stemmed from my drug use. I began caring less about myself and others. Outreach has really made me realize how important family is. If I was out of state in a program where my parents were not involved, I would have never been able to strengthen my relationship with them. My father told me that I've inspired him to make changes in his life, and that meant a lot to me. I've never heard my dad be inspired by something before, and I was just proud that it was me.
Welcome back to Resolutions for Recovery. And tonight we're discussing medication-assisted treatment. And, you know, I guess over the past really 10 years, dealing with a little bit more than that, dealing with my son and what have you, and the education that I've gotten, we really have taken so many steps forward. I would still love to be able to say we could prevent some of this from ever happening, and God willing, one day we will, because this epidemic is just destroying so many families.
So you bring up an issue that always has disturbed me. Maybe somebody somewhere has already approached the issue, and I think we may have brought it up on a previous program. You know that little wheel that's about that big around, and it's got a stem, and it's got a smaller wheel on top, and the baby sits on it and spins it, and then they love it because they get up and they wobble all over the place. We didn't teach them that to change their sense of reality. They like it. So I have a feeling that change of reality is something we do. It's inborn, and maybe we do it to relieve the stress of everyday life, or maybe, although I don't know what a 2-year-old would be stressed about.
But you know, but it's a feeling that you get.
Yeah.
You know, it's
like
being
it.
on a swing
So
and then putting your head upside down.
Yeah, so it's got to be dopamine. So I'm not sure we could, in individuals who are at risk, that we could prevent this disease entirely. But I agree with you that certainly, you know, there are individuals, and you know many of them, who are working very diligently on prevention. And as we learn more about the genetic nature of people who become addicted, we can target certain individuals and at least point out to them that they're at risk. So if you have a mother, a father, a sister, or a brother who, for example, is alcoholic, okay, then you need to understand that you are at risk when you're exposed to an addictive substance.
Just like if your mother and father and your grandparents on both sides have diabetes,
Correct.
You're at risk.
Absolutely. Correct.
So you need to eat healthy and exercise and do all of those things.
Correct. So with addictive, now that doesn't mean that you can't drink or you can't take a painkiller. It just means that when you do that, you are at increased risk over someone who doesn't have that family history. So, and the same thing is true, as you point out, with diabetes. It doesn't mean that if you eat too much sugar, you'll definitely become a diabetic. But if you have a family history, you're certainly at a higher risk than someone else.
To be overweight and
Correct.
You know.
So those are very valid points, and I think the audience has to understand that when we speak about risk, it's not something that's guaranteed to happen to you or your loved ones. It's just something that they should be aware of. And when we speak of prevention, we need to speak about, you know, targeting those people at highest risk. Yes, we can say that doctors prescribe too many opiates, and we've said that.
Correct.
Okay. And so we've limited the number of opiate prescriptions well, maybe not the number of prescriptions, but the number of pills they can prescribe
days
at any given time. And many hospitals have actually limited their surgical staff to even less than that. They say 3 days.
That's awesome.
And
That's good.
Here's what one of my colleagues said, which I thought was kind of wise, although simple. And he said, I don't know about you, but if I had an operation and I needed narcotics 3 days later, I need my surgeon.
But he's absolutely
Right,
correct, though.
because within 3 days you should actually be doing okay.
You should feel better.
So we've limited those that, and that's a good preventive technique. But will that eliminate addiction or exposure? Well, it may remediate some of the exposure risk that we have around, but there's still plenty of addictive things out there.
Absolutely.
That you can end up with. And there are many addiction specialists who feel that some of this is triggered. What we mean by triggered is you turn the switch on, and that's hard to turn off.
You know, I remember my son, that's how I picture it in his brain, that light switch going on that could never be turned off again.
And
why him, not my other two? You know, we don't know why.
No, but you know, if the genetics were setting up
Yes.
right, that may be what happened. The other issue is that the younger brain, as we've discussed in other venues, and
Yeah.
certainly any audience that's watching you now is familiar with this, that the younger brain is not fully developed. Its ability to interpret risk-reward is really not there yet. Not that it's impaired, it's getting there, but it's not there. And I would ask anybody watching us to think about something they did at age 16 or 17, and then think about it now as an adult. Even if as an adult we're talking about 25 or 26, would you still do that again? And the answer is always, are you kidding me? I could have died. I would never do that again. I could have had a broken arm.
I always remember my parents saying and I'm the youngest of 5,
Yeah.
what were you thinking?
Yeah.
I don't know. I probably wasn't thinking.
You weren't thinking, right.
Because
your brain wasn't set up for
that's
that.
kids.
So that's the prefrontal cortex. That is our risk-reward center, and it matures around age 25. And so what we find is that kids who get addicted or get exposed chronically, I'm going to say chronically tongue-in-cheek a little bit because I'm not sure what that means, but they're exposed actually change that prefrontal cortex and their brain. So when we say addiction is a complex brain disease, it is not a complex psychiatric brain disease. It is a complex psychoneurologic disease that affects the entire brain, and the brain physically changes. Now, when you look and you say, well, we're going to put this patient into recovery, you kidding me? I mean, look at what you have to deal with. You start with your cup of coffee. Okay, your caffeine, it's a little addictive. All right, fine. We tolerate that addiction, most of us. Some of us can't tolerate it, but we tolerate it. But at the same time, you know, you smell the coffee in the morning and you start to feel good all over and you start to think about this and that and the other thing, etc. It's all over your brain. Well, nicotine is probably the most addictive substance known to mankind, and yet it's available all over the place.
And
now we're
alcohol.
starting to try and get and alcohol. So teenage brains are exposed to this stuff very commonly, and we tried prohibition; it didn't really work. So
Right.
I'm not going to.
You know, it's funny.
suggest
So I
that,
took
but-
a course last week, and it said in the United States we have the toughest alcohol laws, and how's that working for us?
Well, so that's a problem. Now, to go back to the benzodiazepines, and without getting people lost in the neurochemistry of this stuff, benzodiazepines are similar in action to alcohol. And so what do we see happening? Well, number one, we see people who are in recovery from alcohol being prescribed benzodiazepines. That puts them at risk for relapsing to alcohol again because you're sort of giving them a similar substance. So that's issue number one. Issue number two is that people who use benzodiazepines chronically end up becoming addicted to it. And just like, you know, any other drug of addiction, you get tolerance, and you're able to take higher doses, and you don't get the same effect that you wanted. So now I have people coming into our addiction recovery center, Seafield Center, and they are not just alcoholic, but they're also on benzodiazepines. Some of them are on opiates as well as cocaine. They're on multiple drugs, all to stimulate that mu receptor to get more dopamine out. But when it comes to me trying to detoxify them and put them into a relatively, at least chemical recovery, because remember, and you agree, the recovery is more than just chemically recovering. I'm looking at it and saying, well, I can get them off alcohol relatively rapidly. I can get them off opiates relatively rapidly, but benzodiazepines? Are you kidding me? It could take 6 months or a year to get off some of those. And so we have a major problem, and in fact, the most recent literature, it's in the New England Journal of Medicine, one of the most respected journals in the world, actually. There's an article there written by a highly esteemed individual who says, look at the death rate from benzodiazepines over the last 10 years. And it's unbelievable. So he titled his article, "The Next Big Killer," or something like
That's
that.
frightening.
I may be paraphrasing it.
No,
but
it's true. But it's absolutely 100% true. You know, and I think that also in this day and age, children, young children, kids can't sit still. That's the nature of being a child.
Yes.
They're not ADHD. Some of them are, and I'm not disputing, you know, but I think that we over prescribe for a lot of different ailments, and I'll use that in quote because they're not ailments. They're lack of running around because we cut gym, and it's lack of a lot of things but all those things that we give our kids, Ritalin or Adderall, are changing their brains, setting them up for the next big thing for them in their teenage years.
Yes.
So I you know, for me, the least amount of drugs that we could ever use is always going to be the best.
So somebody
That's my theory anyway.
Somebody coined the phrase cosmetic pharmacology.
Yes.
That's what we do, unfortunately, all too often. And it's a major problem. Now, I don't know whether the computer algorithms that we're coming out with now are going to help that or hurt that. I can't, you know, I'm not familiar with enough of them now, but I know that if you're going to practice medicine, you need to be circumspect about the use of medication. It started with the antibiotics.
Yes.
Where we're now at a point where we're trying to play catch-up to the organisms that have already beat us to the punch in terms of developing resistance to many of these agents that we use, that we depended on.
You know, it's funny, when I used to take my kids to my pediatrician, and I loved those guys, and I'd say, if they don't need medicine, I don't want medicine. And they wanted to hire me just to tell other parents that when they came in, if it's a virus, it's a virus. I'm just here to make sure it's a virus, that's all. But if we don't need anything, I don't want anything. But there are many people that feel, well, I came to the doctor, you have to give me something before I leave here.
Okay.
Whether
Now,
you need it or not.
So here's what happens now. And unfortunately, this is true with narcotics also. It takes a doctor maybe 5 minutes to explain to you what you just explained to me about viruses don't respond to antibiotics, don't take it because there's a downside to antibiotics, there's resistance, there's the fact you could be infected with a superbug, etc., and it could kill you, right? Especially now in the flu season when people are, you know, oh, you know, everyone gets a Z-Pack now, it's the big thing, Z-Pack. The azithromycin by itself can kill certain people, but now you're adding it to a viral disease. It turns out that as we put more pressure on physicians to see more patients because we pay them less per patient, it takes maybe 5 minutes to explain why you don't give them an opiate for their pain, or you don't give them, or how they're going to handle the pain. It only takes 10 or 15 seconds to write the prescription.
Right.
Now, if you have to see 6 or 7 patients an hour in order to pay your loans off, to pay your malpractice insurance, to pay your office staff, to pay your rent, to pay whatever it is, your licensing fees, etc., your CME credits, etc.
Yeah.
If you've got to see so many patients to do that, you can't afford to sit down and talk to a patient. You literally can't afford to do it. Now,
And that's
we
a
all
sin.
agree we need to
Yeah.
do that, and we got physician assistants, we got nurse practitioners, but guess what? We're putting the same pressure on them. And indeed, they may not be as skilled as the physician, as the family doctor,
Yes.
to be able to say, hey, this is a virus. I know you're sick. It's really sick, and I know people have died from it, but that doesn't mean the antibiotic is going to
gonna
help you.
Right.
It may, in fact, kill you. So here's the medicine that we think will help you, Tamiflu, if you will. I hate
Right.
to use a brand name. But here's an antiviral. You should take this. It may shorten the disease by 3 to 5 days. And what will be in terms of, bed rest and soup. Chicken soup is always okay.
It's always good. I think
right?
just bed rest is
Right,
always
and
good.
and that's it. And you'll get better. But it takes time.
It takes time. But also I
doctors
think
don't
in
have
this
it.
day and age, there's surveys with doctors.
Yeah.
But if you and I go to the same doctor and I come out with a prescription, we both go in with back pain, and your doctor says, Michael, you're 20 pounds overweight. I need you to exercise. I'm not going to give you any medicine. We're going to send you to physical therapy. And then you talk to me and I go, oh, my guy gave me, a narcotic.
That's the problem.
You're going to be upset. You're going to go to my doctor.
Yeah. Well, yes, and
That's
that's
not
another
the,
problem.
the right course of treatment is what you were told.
Yeah.
But people want immediate gratification to their pain that they're feeling right now today.
So, and nothing could be more true. But the other thing that I really want people to understand about this, to get back to our original
Yes,
issues,
our medicine.
is that some people who suffer from addiction don't go into or try to go into recovery for a couple of reasons. Probably the first is that they're afraid of the suffering that they'll have.
Yeah.
But there is no suffering, okay? For alcohol and for opiates, we have good protocols to relieve the withdrawal symptoms over the course of 4 to 5 days. Some people don't even require that much, but at least it's there and they don't have to worry about the physical issues
Okay.
related to it.
And that's big because I know withdrawal from opiates won't kill you. You may want to kill yourself.
Right.
And you may think you're dying in the
Right.
interim because it is very, very painful.
Right, and people with heart disease obviously don't want to go through
Yeah.
that. Alcohol, though, and benzodiazepines can kill you, but that's separate. Alcohol we can do because it's a short-acting drug.
Right.
Anybody who's alcoholic knows that in 3 or 4 hours they need another drink.
Right.
Right? If they wake up in the morning because they've had 8 hours of sleep, they're shaking like this because they're in withdrawal. They have to have a drink. So we can handle that easily in most cases. Even in an outpatient setting, we can do that for both opiates and alcohol. We have an inpatient setting for people who are more severely affected by the disease, and we have outpatient clinics that are available also throughout the state. The issue then becomes one of, well, okay, if we can do that for people, and this issue why aren't they availing themselves of this? It's not most of the time an insurance issue, because most of these places will take Medicaid, which,
Yes.
okay, and many hospitals will get Medicaid for you. So
Correct.
So that's not the issue. So why is it that people aren't coming? And that issue is they're embarrassed.
The shame and
And
stigma
what
of this
the
disease.
stigma, and that's the magic word. The stigma is keeping people
Alive and
I can't
well.
begin to tell you how many people. And the families, and this also, are supporting that by saying, oh, it's not that bad. I love the statement, well, at least it's only marijuana. When they talk about a kid, and I'm saying, oh my God, what's going to happen? We are, as a society, and I'm not talking about just New York, I'm talking about addiction professionals in general, marijuana is an addictive agent, period.
Period. Absolutely.
Don't even want to hear an argument about it. I don't care about using it recreationally. I don't care if it decreases the number of heroin deaths, et cetera. By the way, that's starting to peak now,
Yeah.
so they're starting to go up. But the point is that it's an addictive substance. And sometime in the future, we're going to be fighting the same fight we had with nicotine.
We're already fighting that fight.
Yeah, but
especially
now
with-
you got a lot of big dollars behind
Yeah.
pushing this stuff. Same dollars
Well,
that push the other stuff.
Absolutely. It's tax money. Always follow the money, right, Doc?
Always follow the money. That's
Always
true.
follow the money. So, but exciting now. I know that you spoke at Good Samaritan Hospital
Yes.
down in West Islip
Yes.
last week to all the physicians, the
Yes.
emergency room physicians,
Yes.
about doing the Suboxone induction right
Yes.
then and there in the
Well,
emergency room.
it's not an induction though. It's a it's inappropriate for you to show up in an emergency room like after you've recovered from an overdose, and for them to say, "Okay, you recovered, go home." What are you going to do? You're in withdrawal because you got the
Yeah.
Narcan, and now you're shaking like leaf. You're going to go out and you're going to find somebody
You're
to
gonna
get your
use.
stuff, right? So the New York State, recognizing this Department of Health of the State of New York, as well as OASIS, the Office of Alcohol and Substance Abuse Services for New York State, said, "Hey, why don't we give them a dose of buprenorphine because they're in withdrawal? Why don't we give them a dose of buprenorphine, which lasts a long time, and let them find a provider or a clinic that will continue them on buprenorphine, or at least help them get into recovery?" Okay, well, the government actually cooperated in this case, and they said, well, we have a 3-day rule that says that you don't need to be specially trained to order 3 days' worth of buprenorphine. You can just order it. You can't write a prescription, but hospitals have buprenorphine, so you can give them Suboxone on day 1, 8 milligrams or so, and that will take them out of their withdrawal because they're in withdrawal. You
They're
can't
in
give it to them
yes.
if they're not in withdrawal because that will push them into withdrawal, because remember I said buprenorphine is stronger on the immune receptor. Or if they come back the next day because you couldn't get them into a program, you could give it to them the next day and the next day. So 3 doses they can get over 72 hours, okay?
And they have to come back to the
Well, they would come back to the
emergency
ED, but you know that's up to the hospitals how they want to set that up.
Okay.
Now, recognizing that, again, this becomes a cost center, and there's not a lot of money around. In fact, nowadays
Yes.
there's even less money. I'm not going to go into that.
Yeah.
But the fact of the matter is that, well, who's got the time, to do this? And what we have, as you're well aware, we have peers.
Yes.
Who are peers? Peers are people who have been in recovery, have been trained somewhat.
Yes.
They have a whole
They have to
course
take
and
a
they
course.
qualify.
I've taken
and
the
now
course.
they're available to help others suffering from that disease. So they have the disease, and that gives them an insight, and they're in recovery, which is even a greater insight. And now they can help people, and they have the time. And
So-
so we're going to put peers in there. And Good Samaritan Hospital in West Islip is one of the first in-services we've done. I mean, there are other hospitals throughout the state where they have even more robust programs because they have a physician who is interested in doing
Yes.
that. Dr. Ross Sullivan is
He's up in
is a-
Syracuse.
oh,
he's
he's a god.
amazing.
Right,
Yes.
because he set up a whole clinic right next door
Yes.
to the, and he wasn't an addiction specialist, he was an ED physician, is an
But
ED
he-
physician.
but he saw the
He
need.
saw the need, and he trains young physicians who come in there, residents, et cetera, and how to do this, and so people get recovered in the emergency room, and if they want to, again, it's voluntary, they
Yeah.
get an appointment right away in his clinic, which is
It's a
really
beautiful thing.
busting at the seams now. Right, it's really, and there's
But you know what,
there are a
Doc,
couple other
also-
hospitals doing that.
I think for Dr. Sullivan too, so we'll just use him. You meet a doctor in the emergency room after your, overdose or whatever, and someone saying, you know what, I could help you.
Yeah,
I can help you. I'm concerned about you.
right.
Sometimes that's all you need to hear.
Well, that's what the peers are going to do.
Yeah.
So they will come, and again, it's by permission. That's
Well, you have to want to
so you
speak
have
to
to
them.
right. So
Right.
that's
and
a
the peers
problem.
are different than a sponsor in a 12-step fellowship.
Correct.
They're different because I'm a peer advocate, so it's a different way to listen. It's a different way to respond.
Mm-hmm.
It's kind of just being that person that maybe can listen
Yes.
and repeat back, so that they can,
And has been through your experience.
and has been through the
Right.
experience.
So yeah, they're not there to judge you, etc. They're there
Or
to
criticize,
tell
they're
you,
just there
and even if
to
it's,
hold your
right,
hand.
And even if you decided not to go into the recovery that they suggested or whatever, they're still there to hold your hand. And
Absolutely.
there's no judgment on
No
their part.
judgment, no,
Right.
because one day the hope is that you will be ready to go.
Absolutely correct.
For Thomas's hope and for what I do, I'm not really going to connect with the affected person, but the family. Because when we bring the family into treatment, right?
Yes.
Because they're struggling with substance use also.
Correct.
And they need their own toolbox, and they
Correct.
need their own set of things that they can do for themselves. That's going to help both
Right.
sides of the fence there.
And the recognition as to what they're doing that's good and what they're doing that's enabling.
Yeah.
And we're not talking about, some people use the term enabling as a dirty word. It's a word. It's a useful comment.
What I like to say is to parents too is we're not worried about tough love. We're going to teach you how to love tough.
Yeah. Okay.
Different,
So
just
that's
a
good.
different play,
Yeah.
but you got to love, you're going to love them, but you
Right.
got to be willing to say no.
Correct. So I'm really excited about this
I am
program,
too.
and then the state is going to try and get this statewide, and ISAM, my organization, may be involved because we have representatives all over, the members all over the state, and they'll just have to go to the hospital and teach the ED director about these the 3-day rule and what can be done, etc. The other thing that's important for people to know is that if you're on buprenorphine maintenance and you end up in a hospital, you do not need a waivered physician to continue that buprenorphine maintenance. The hospital can maintain that because you're already on it. That's part of the federal legislation also.
Awesome.
So that's important because many people, critically ill, have ended up in the hospital, and the hospital says, "Oh, well, we can't handle this. We'll have to detoxify you." No, you don't have to detoxify because you can't stop buprenorphine suddenly, like any other drug.
Correct.
But the point is, they can maintain you on it, and if you need pain management, then they can do pain management on top of the buprenorphine if they need to. There are multiple ways to handle pain, not just with narcotics, as you're probably well
Right.
aware.
Absolutely.
So that's issue number 2, and issue number 3.
Doc, but if someone's in the emergency room, do they have to go back to the hospital, or can that 3 days be dispensed?
No, they can't.
Maybe to
They can't be given. They have to come back, but
Okay.
they don't have to come to the emergency room. Depends on the hospital.
Okay.
Obviously, it's going to be a cost issue to the hospital, so they're going to have to
Correct.
work that out. But one of the things that the state is interested in doing, the buprenorphine working group, of which I'm a member, is they want to make certain that ED physicians, at least one ED physician, maybe per shift, is waivered on buprenorphine, so that physician could write a prescription for a month for a patient.
Okay.
Okay, now, the details on that still have to be worked out and looked at, et cetera.
But we also have the 24-hour access coming into play. Maybe, the emergency room can hand it off to their,
Well, yeah, absolutely. Well, as Communities of Solutions,
Logistics,
of which
yeah.
we're both members, they are publishing access to care documents that show who's available, where they're located, and who they take.
Our hour always goes way too fast. That's
Was it
for
an
sure.
hour?
It was an hour
Oh, I
already.
thought it was half an hour.
Thank you. So, anybody that needs any information on medication-assisted treatment, please reach out, send an email, hit the Facebook page. We'll get you information on this. It really is a lifesaver for your loved ones. Have a great rest of the week and a great weekend.